Welcome to Dateline Health. This is Fred Lippman coming to you from the Alan B. Levan Innovation Center at Nova Southeastern University, which is a venue which is a combined effort of Broward County and NSU. We found out that we have one of our really significant experts in the issue of ACL tears and common injuries that are now have new, shall we say, applications of treatment. So Dr. Stiebel is with the Anderson Family Orthopedic and Spine Center of Excellence at Jupiter Medical Center. Welcome, Dr. Stiebel.
Thank you. It's a pleasure to meet you and to be here.
So talk to us about what you do and how, shall we say, successful you are, which I know you are.
Yeah, thanks. So I am an orthopedic surgeon, and I practice in a field called sports medicine, which means that I did extra training or a fellowship in sports medicine. I did that in Boston after med school at Yale, and then some residency at McGill in Montreal. And what I have been specializing in is a lot of injuries around the knee and shoulder. Those are the two areas that I spend most of my time looking at. In the knee, one of the things that all orthopedic sports medicine doctors think about a lot is ACL tears. I've been in the area for about 13, almost 14 years. And during that time, I've taken care of all sorts of athletes across the board, from professional athletes to weekend warriors to parents of athletes who have injuries. An ACL rupture is a tear of a ligament in the middle of the knee. And what happens is when we tear this ligament inside our knee loses some stability, because the ligament helps the joint function normally. And without it, the knee joint starts to pivot or move around in a way that it's not supposed to. This is the injury that many of your viewers will recall happened to Tiger Woods and Tom Brady and other famous sports athletes. When we have this injury, what tends to happen is we can't participate in sports that involve pivoting or side-to-side motions because our knee just won't support us correctly anymore. So for people who have ACL tears and want to participate in sports or do side-to-side activities, they usually need an ACL reconstruction or a new ACL. There are different ways to do that. Yeah. There are really 4 different ways that we do ACL reconstruction in today's world, outside of this implant we're going to talk about, the Bear. In a normal ACL tear, we can't usually repair it because when the ligament ruptures, it blows apart in the middle and into a lot of fibers, like rope being broken apart. Every now and then we can repair it back to where it's torn, but for the most part, we cannot. We haven't seen the ACL regrow itself back into bone like other ligaments do. For instance, there's a ligament on the inside of your knee called the MCL, or medial collateral ligament. When we tear that ligament, most of the time, it heals on its own. So the question is, why does that heal on its own, but the ACL does not? And the answer, I think, that we've come to is the fact that inside a knee joint, there's a lot of fluid. It's called synovial fluid. And inside the synovial fluid are enzymes that break down collagen or protein production. So things that tear inside a joint don't necessarily heal because of all of the enzymatic reactions. So we repair ACLs, or we reconstruct ACLs, with 4 different methods right now. The first method is we can take part of your hamstring tendon to repair your ACL. So we harvest some of your hamstring and we drill holes in the femur bone and the tibia bone, and we put the hamstring into the middle of your knee, and your body grows into it and it turns into a new ACL. The second way to do it is with your patellar tendon. So we take a piece of bone from your kneecap, part of the tendon, and part of the bone from where the tendon attaches to the tibia. And we do the same thing that we do with the hamstring. We drill holes in the tibia and femur and put it in the middle of your knee. We can also do the same thing with a piece of tendon from your quadriceps or from a donor tendon, which means that we take it from a cadaver that's been processed sterilely, and we take some of the dead tissue and place that inside your knee. All of those things are called ACL reconstructions because we're not fixing anything, we're giving you a new one. And all of them have pros and cons. Nothing in life is free. Sometimes we have to rob Peter to pay Paul. So if we take part of your hamstring tendons, you may lose some hamstring strength. If we take part of your patellar tendon, you might end up with anterior or knee pain in the front of your knee, and so on and so forth. So nothing is without consequences. Right now, orthopedic surgery is on the cusp of a new transition. And the transition is to try and create healing with biologics. Things like stem cells or PRP or newer technologies to get the body to heal itself. I think that orthopedic surgery has gone through a bunch of different waves of innovation. The first wave of innovation is when we started putting plates and screws on people's bones to get them to heal. The second wave of innovation, in my opinion, was total joints. New knee replacement, new hip replacement that changed the way we think about orthopedics. The third wave of innovation was using minimally invasive surgeries like cameras or scopes to go down in to do surgeries. And I think we're on the cusp of the fourth wave, which is to use biologics to fix things, to fix or regrow or treat problems such as cartilage or ligament or tendon. What's exciting is that this has come to the ACL. And this comes to the ACL in the form of an implant called a BARE implant, which stands for Bridge Enhanced ACL Repair. Okay, so what we're trying to do now is create a bridge so that the ACL can repair itself in the same way that the MCL or the medial collateral ligament can repair itself when it's torn without surgery. So the BARE implant is a plug that looks like a marshmallow, and it's made out of bovine cartilage. And what we do with it is we sew it into the knee and connect the stumps of the torn ACL. And that provides a beautiful scaffold so that the ACL can grow through the BARE implant and reconnect itself and create itself a brand new ACL that was very similar, or if not almost identical, to the ACL you natively had before you tore it. And that's neat stuff. That's new stuff that's just sort of come out on the market. It's been tested for the last number of years out of Boston Children's Hospital. There are some really excellent, what we call level 1 randomized controlled clinical trials on it, where they've done lots of work on a number of recipients of it, and the outcomes have been pretty excellent. They've been at 2 years, the scores on what we call a knee score is identical or better than that of people who've had ACL reconstructions. And on top of that, there's a higher return to sport. And it's trending in a way that makes us think that it will reduce the amount of ACL tears on the other or contralateral knee. Because what people don't always understand is after you tear one ACL, your rate of tearing the ACL in the other knee is high. It's up to 30% if you continue to play sports. And we think that happens because patients who get new ACLs from dead tissue don't have the same proprioreception in their knee. And proprioreception is a fancy term for knowing where your body is in space without looking at it. So if you have better stability and control of your body, then we think that it protects the other knee better. And when we regrow an ACL, all of those nerve fibers regrow too. And that's pretty exciting and new.
Let me try to, I didn't mean to, the reason that we wanted this conversation to occur, Dr. Stiebel, is, you know, we have been doing this show for 23 plus years, and the questions come from the viewers. And there's so many questions. Now, there are two things. Number one is, obviously you know, living here in South Florida or in Florida, that, you know, we have the highest number of people percentage-wise, of over age 70 of any state in the union. And we have the greatest number of people over 85 that are living here that are of any state in the union. And we got a lot of questions from these groups because they want to be normalized. In other words, they don't want to be sitting in their apartment or their condo or their home or their assisted living facility, whatever it is, they want to move about, all right? So that's one area. The next area of questioning came from parents who have children, whether they're children of little league age or college athletes, or even some that we had that would go beyond college into professional sports, that they queried, where can I get information about ACL tears? The parents particularly, the number of questions that we got from parents, because they're fearful. Maybe that's an overstatement, but they're worried, let's put it that way, that their child is going to be injured, and what does that provide them for the rest of their lives?
So that's an excellent question. You know, there's over 400,000 ACL tears a year in the United States. So it's a huge number. And it is in a higher ratio of women to men. And we're not 100% sure why. It may be the alignment of women's knees. It may be the size of the notch. It's unclear to us. It may be muscle development. There's a bunch of different things. So it's truly a nationwide, I won't say epidemic, but a nationwide problem in high volume. One of the issues with tearing your ACL, especially at a young age, is the potential after the ACL is reconstructed for later in life arthritis in that knee. That's what people really worry about a lot. Arthritis means lost cartilage. That's that smooth, slippery Teflon on the end of your bones, and that's what helps the joint slide and move normally. As we age, sometimes that cartilage starts to change, and we get what's called osteoarthritis. In younger patients who have trauma to their knees, like an ACL tear, they may go on to have earlier arthritis and what we call post-traumatic osteoarthritis. So to try and combat that is always in the minds of orthopedic surgeons, because we like to take care of our patients, you know, from the age that they get injured all the way up through their retirement and beyond. And we're looking at our patient as a whole person for a long time. One of the things that really attracted me to this Bear implant is that if we're able to regrow the ACL, the risk of arthritic transformation might be different as the patient gets older. And the reason for that is no matter how good a surgeon you are, when you put in a tendon in the place of a ligament to sort of rebuild the knee, it's never exactly the same as the native ACL. It has different biomechanical properties. It has different tension to it at different ranges of motion, and it has different effects when placed under load. If we can regrow your own ACL, it may be that that mimics your original ACL and does not lead to the same level of arthritic progression in your knee because we're giving you a more natural, normal knee. We don't know the answer to that yet because the studies are only a few years old, but that's something I'm definitely looking at. And that's something that I think is really exciting about a newer technology like this. And I think that our older patients will appreciate that because they're often the ones with osteoarthritis. And our younger parents will appreciate that because they know we're doing the best thing possible for their children who are sports athletes.
You know, that brings me back to your mentioning about the biologic influence on the care of this particular ACL issue. It seems to me, and again, I don't stay up with all of the medical journal, shall we say, communications that I get, but I do read a lot about these type of injuries. And to tell you the truth, it's come to affect 2 or 3 people in my family structure, all right? And it's really very interesting to hear you talk about the advancement of thought, which is, I think, first, in the care of medical care, there has to be thought first. And I think that the fact that biologic care is becoming more, shall we say, preeminent, I think that that is a magic wand. And I don't want to overstate it, but that's the best way that I can communicate the issue. Do you feel that way?
I do. I think in the future, we're going to see more biologics. I think things were tainted in the United States, especially in South Florida, with an overpromise of things like stem cells. And the FDA has really cracked down on that kind of thing. What's unique about this implant is that it's undergone randomized controlled trials so that we have studied it to the point where we understand we've done this versus controlled groups and we see quite a difference. We understand that this is working. With some of the things like stem cells that people were randomly injecting with different values and volumes, no one really knew where it was working because it hasn't been studied well enough yet. But I agree with you, and I think that the future of medicine, specifically orthopedic medicine, is biologic-based. It may be stem cells. It may be genetically modified cells. It may be something else entirely. But in order for it to really be released to the public, what's important is that it undergoes careful scrutiny and careful clinical trials. And that's why the Bear is special, because it's done that. And it's really shown itself to be a novel treatment with high efficacy.
Let me ask you this. If the people who are watching us want to get to Matthew Stiebel, they have to be referred by their family physician, et cetera, et cetera, et cetera. Tell me the action.
Well, typically what they have to do is call my office and say, I need to see Dr. Stiebel. And our office figures out a way to get them in. That's typically how it works. They can say, listen, I have a knee injury, I have a shoulder injury, something's going on, I need to be seen by an orthopedic surgeon. Many plans don't require a primary care referral. Some do, some don't. Each person has to check with their own plan. But typically when they call our office and they have a discussion with the person at the front desk at Palm Beach Sports Medicine, the woman or man at the front desk will say to them, listen, what's your insurance? And then they'll look at those kinds of things and help steer the patient either through primary care or directly to us.
Well, the other thing is knowing, as I said in the early part, when I started to talk about people over the age of 70, et cetera, there are a lot of those folks. They want to be, they want to be whole. In other words, they want to go out to dinner. They want to go here. They want to go there. They have to step here and step there without falling, which is I would assume, and we'll get to that. I would assume there's a lot of context relative to the injury and then the next portion, which is unfortunate, a trip and fall. But we'll talk about that in a second. What I'm wondering is, is this a situation where those people who are on Medicare have this available service?
Yes. Now, most of the older patients that I see, older, over 65, don't have ACL injuries. They have other injuries inside their knee. They have more frequently than not arthritic changes inside their knee or lost cartilage. And that's what stops them from doing the activities they want to do, particularly in a pain-related way. And so the nice thing about being a surgeon who does everything in the knee, from cartilage work to ligaments, all the way through partial and total joint replacement, is that I can sit down with those patients and say, listen, maybe an ACL is not your problem. Maybe cartilage is your problem. Let's talk about treatment pathways we can take, non-operative treatment pathways or operative treatment pathways. And we kind of go through everything with the patient in my practice here.
Is the actual operative procedures done at Jupiter Medical Center, or do they have a surgical outpatient unit someplace else?
Yeah, they do, but I do them at Jupiter Medical Center. I think that the Anderson Family Spine and Medical Center there is terrific. I think that the level of care that they get out of Jupiter Medical Center is really second to none. And I think that Jupiter Medical Center is really special because they have really encouraged me specifically and others to really look at new technologies. They were excellent when we did some clinical trials for the FDA with some implantable devices of the knee, and that was done at Jupiter, and that was terrific. And really now they've been first on board to help promote new things for the community, because I think they're trying to stay on the cusp of technological development to give patients at Jupiter Medical Center really the best possible healthcare they can get. It's really well beyond the level of what you'd call a community hospital.
That's great. The only reason I ask that is because I'm sure there's aftercare. In other words, there's physical therapy, et cetera, and someone from Dade, Broward, and maybe even Lower Palm Beach, whatever, it might be difficult for them to travel, et cetera. But that's why I asked the question. But it's all in the process of family and significant others that have to help you get there. That's all.
Absolutely. And for aftercare, for physical therapy, we have protocols and guidelines, and we give those to the patients with their prescription for physical therapy so they can really go anywhere. We have patients that are flying in here for surgery and they go back home to wherever it is they need to be. And we keep up with their physical therapists, making sure that the patient's meeting certain milestones, as well as the fact that the therapist is adhering to our protocol sheets, because we're very specific, especially after I've touched someone. I want things to go a certain way.
Well, that's great. Being someone who has had the opportunity to put myself in a situation, I didn't put myself, I was brought into the situation of having to have physical therapy. I am amazed at what can be done with what I would call a fully knowledgeable, capable physical therapists that work in tandem with the prescribing physician. I think that's a wonderful opportunity for care. So I know what you do. Go ahead.
Yeah, oh, absolutely. I work very closely with physical therapists. In fact, we have some in-house, and my chief physical therapist helped rewrite some of the protocols with the people in Boston for the Bear implant because we wanted to incorporate newer physical therapy techniques such as blood flow restriction technology and dry needling and some other things that are sort of new to the market to make sure that people got the greatest level of care, soup to nuts, from the operating room through rehabilitation. You know, I like to joke with my physical therapists, as surgeons, we break them, and as physical therapists, they fix them. And that's, you know, somewhat true. So you really need a team approach or you don't get the outcomes you want.
Well, Dr. Stiebel, we're down to the last minute and a half of the show. We thank you very, very much for answering our query to find someone with knowledge on ACL tears, et cetera. It's been a question that's come from our viewers a number of times. And we thank you for your work. We thank you for your excellence. I know of individuals that have had work provided by, or I should say work, procedures provided by you. And certainly the word of a spine center, orthopedic and spine center of excellence meets all of the standards that you have discussed. Thank you very much for being here today. We certainly would like to invite you down here to the campus to visit with maybe our classes of physical therapists or occupational therapists. They would get a lot of vim, vigor, and vitality by listening to what you have to say. So thank you once again for being with us. And remember, folks, I always tell you, you got to take good care of yourself. If something's bothering you, you got to tell your doctor. This show is called Dateline Health. If you have a question or you need an answer, there's an address right here. And remember, the show is called Dateline Health. It comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.